So Theresa did her Ph.D. at University of Virginia and then postdoc at Cold Spring Harbor. We overlapped for about 6 years at Merck. And, she actually does marathons. It's a different kind of marathons. She commutes between Maryland and Boston routinely every week and shows the commitment she has for her family and her job. And she works at PGX. You've been there for a couple of years there? 2.5 years. And yeah, it's a great pleasure.
Back and forth from Boston and Baltimore.
Different kind of marathon. And yeah, she's Vice President of Translational Research and Diagnostics at PGDX. And she's going to talk about novel therapeutic and diagnostic applications of circulating cell-free tumor DNA.
Thank you, Oscar. So I'm going to talk about ctDNA. And I structured my discussion into 3 parts. First is some background, and then I want to focus on some considerations when working with circulating cell-free tumor DNA, and last is clinical application. So the first part, the intra part, a few really important points. How come it doesn't work? Thank you. Wrong button. So the first point is majority of the cell-free DNA in plasma are actually coming from wild-type normal cells. And tumor cells contribute to a very small portion of the DNA in plasma. And all the DNA wrap around nucleosome and are protected in plasma. So if you look at the fraction size of the DNA, it tends to be have a peak, and then it's a lateral pattern. The smaller fragment, right now the thinking is they're protected by transcription factor binding site. They're protected by transcription factor binding. Also, they could be just some breakdown of larger DNA pieces from necrosis. Another thing about the circulating tumor DNA is their short half-life, which make them very informative of the real-time reflection of what's going on in tumor, which have implication for monitoring tumor burden. So the key point is circulating tumor DNA are specific to tumor. We mainly look for mutations, copy number gain, or translocations that happen in tumor only. And it's a good way to get a handle on tumor heterogeneity because multiple clones in the same lesion or multiple lesions, they shed to the same central sewage system. Of course, the challenge is, as I mentioned earlier, most of the DNA are actually wild type. So most of the times, the fraction of tumor DNA in plasma is actually very low. So how low it is? If you look at the distribution of circulating tumor DNA versus fraction of patients, if we focus on late-stage patients, about a quarter of the patients have relatively high tumor DNA level in plasma, over 10%. For those patients, just use a regular tissue-based NGS platform. You can identify tumor DNA with sufficient accuracy. But if we move the dial, if we look at 1% tumor DNA, this is sort of the lowest you can go with NGS platform without any error suppression. Where at this level of detection limit, you can have an assay that is informative to about half of the patient. But for assay to be really useful, you need to have the assay informative for probably 80–70% of the patient. That means your assay has to have a detection limit of 0.1%. So that's where we are aiming our assay at. And just looking at the different stage, looking at the medium circulating tumor DNA level, as you would imagine, at the early stage, stage 1 and 2, the tumor burden is lower, so the shedding of tumor DNA into plasma is a lower amount. So the medium circulating tumor DNA level is also lower. That medium circulating tumor DNA goes higher as the tumor progresses. So what are the main approach when we have to detect such low fraction of tumor DNA in a big collection of wild type DNA? I think Matt, is it Matt or you? Okay, Oscar mentioned the digital PCR, which is actually the workhorse for liquid biopsy, analyze circulating tumor DNA. The advantage of digital PCR is it's relatively inexpensive once the assay is validated, and the sample requirement is very low, and also the turnaround time is fairly fast. The limitation of digital droplet PCR is that the ability to multiplex is limited. So most of the time you can look at probably interrogate 5 mutations simultaneously. And also you have to know exactly what mutation you are interested in ahead of time. So on the other hand, NGS approach allow you to really interrogate the thousands, if not the millions of base pairs. And you don't have to know the mutation ahead of time, just whatever you find in the region that you're interrogating. And also allow you to analyze not only mutation, but also copy number and fusion event. The issue is most of the NGS platform have inherent error rate. So you can't really interrogate mutation with below 1% mutant allele fraction. So how do you use the NGS platform with 1% inherent error rate, yet still detect mutations at 0.1%? So what we do to suppress NGS error is to molecular barcode the molecules and do redundant sequence. So for each of the molecules in plasma, we put molecular barcode, and then we sequence at very high coverage. Ordinarily, for tissue sequencing, you do about 1,000x. That's very high for FFPE sample. But we're talking about easily 50,000x coverage. So the amount of sequencing is very substantial. But what that gives you is you actually sequence the molecule multiple times. And if for sequencing error, because of the stochastic nature of that, the mutations you would observe are actually scattered around. However, if it's a bona fide mutation, those mutations will line up. So this is an effective way of differentiating the bona fide mutation from the random sequencing error. So that allows you to get to 0.1% using a platform with 1% or above error rate. So this is just demonstrating how well this approach works. It actually can go down to about 0.1, 0.2% with NGS-based approach. So PGDx, as other players in the field, has developed large gene panels. Those are pan-cancer panels where the genes are selected based on their clinical actionability associated with FDA drugs or associated with late-stage clinical trials. And also we include a number of genetic landmarks for different major cancer types. So that's a basic concept of circulating tumor DNA. The fraction is low, and you need to do tricks to be able to use NGS-based approach to detect them with accuracy. So there are a number of considerations for doing circulating tumor DNA analysis. First, we hear a lot of claims of different approach where they have very high sensitivity. However, the sensitivity is really limited by how much input you have. The number of molecules you have in the tube of blood we can obtain. And then pre-analytical is very critical. Preservation of the plasma is the key. And also, even though for the longest time we always think mutations we found in plasma associate with solid tumor, but now we also know a lot of those mutations identified in plasma are actually coming from the blood cells. I'll have slides showing this, but as we age, our white blood cell accumulate clonal mutations, and that will show up in your plasma. When we have those ultrasensitive analysis, we actually capture those white blood cell associated mutations. And also concordance between circulating tumor DNA and tumor is always a big discussion at all the meetings. Is what to believe. Should you believe a circulating tumor DNA marker or what you find in tissue? So this is just a little bit more detail on the input amount being really the limiting factor. So if we look at what are the possible volume of input of plasma we got, in reality, most of the times we have 5 ml of plasma that comes from 1 tube of whole blood, which is most of the most common extraction amount. And in the best case scenario, if everything is perfect, you extract all the DNA molecule, and you only need 1 copy of mutant molecule to cause the mutation, you can have 0.006% limit of detection. But however, in reality, when we capture molecule, we never capture 100%. The best you can do is about 50%. And then to read out the mutation, you need multiple copy of mutant read to really give you confidence that is now the fluke. So putting this together, for 5 ml of plasma, which is the most common amount of blood we can get from patient, the best you can do is 0.05%. Even though the approach can do better, but we're really limited by how much molecule, how much blood we can get. In terms of pre-analytical, there are many different tubes you can use. Most common would be EDTA purple top, which is in every lab. The issue there is you have to process whole blood almost right away. The guideline is within 3 hours, you have to really double spin them, which poses problem in many molecular lab. So another approach is using Streck tube, really preserve the blood cells so they don't lysase, so the white blood cell don't lysase and don't release the wild type DNA to dilute your tumor DNA in plasma. However, how can you use those tubes? Always a question. So we have done extensive analysis looking at different time point of processing the blood, and also looking at how do you how do you store the tubes at what temperature. So we get asked a lot about what are the guidelines. So definitely the gold standard is always process the blood right away and freeze the plasma. But you could do with some reasonable, acceptable impact on performance is to process everything within 24 hours. And Streck tubes need to be kept in room temperature, and EDTA tube needs to be on ice. But definitely never go beyond 3 days, 72 hours. After that, the performance just goes down tremendously. So we talked about not all the mutations from tumor. This is the study really demonstrated. So the authors perform whole exome sequencing of plasma, just normal, healthy people. But what they show is as we age, the percentage of participants have mutations in their plasma actually goes pretty high. Of course, we can now filter out those white blood cell related mutations, but you can never do a perfect job because P53 is a big marker for solid tumor, but it's also mutated in blood cell, which really cause problems. Again, another issue is concordance between circulating tumor DNA and tissue. When we think about tissue, it's really a lot of times it's one particular lesion and we poke at one particular part of the lesion. So intratumor heterogeneity definitely causes discordance between what the tissue readout and what could potentially be the plasma readout. And also across different lesions, as demonstrated here, mutations in primary tumor and mutations in metastatic can be very different. And the plasma as a switch system actually have mutations from all of them. So how do you use mutations in plasma to figure out what are the truncal mutations across all lesions? That's a very active research area. So just to summarize this part, the major considerations would be really we need to prospectively collect plasma to make sure we have enough input molecule to work with. And then pre-analytically, the whole blood really need to be processed within 48 to 72 hours and freeze. And when we try to figure out what are the mutations associated with solid tumor, after the filtering, if we still see a lot of mutations that are questionable, it's always a good idea to sequence the buffer code. And definitely the discordance between circulating tumor DNA and the tissue result. I think the latest thinking in the field is really maybe redefine the gold standard. Instead of taking tissue as the gold standard or plasma as the gold standard, it's really the response to therapy. So that's a consideration for using circulating tumor DNA. My last part is to discuss clinical application of ctDNA. So just really quickly, different stage, different amount of shedding, and also different therapy. So early stage, the clinical need focus on early detection and screening. And in intermediate stage, stage 2 and 3, it's really risk assessment after standard therapy, after curative intended therapy, and detect the recurrence. Most of the ctDNA application focus on late stage, where ctDNA is used to genotype the patient to help select treatment and monitoring response and understand resistant mechanisms. So that ties into the level of ctDNA, and that have impact the possible approach we could use. In late stage, because the shedding is higher, we could potentially use NGS panel, but on the earlier stage, just because the circulating tumor DNA level is so low in majority of the patient, right now digital PCR is the main workhorse. So I want to touch upon the companion diagnostic aspect of liquid biopsy. Recently, Roche have the first ctDNA-based assay approved. The assay is for EGFR mutation, both for first-generation EGFR therapy. We know those are the sensitizing mutations, and also for T70M resistant mutation. That's for third generation of EGFR TKI. What's interesting is it's the same assay that approved for both tissue and plasma. Also, the guideline of using the assay, they define it as plasma testing first. So if a patient is plasma positive, means having mutation, the patient will be treated. And if a patient is plasma negative, they will be reflect to tumor testing. The reason for that is not all patients shed enough circulating tumor DNA that can be detected by this assay. So a positive means that patient probably do have the sensitizing mutation, but a negative means you just don't know. That's why you really need to get a fresh biopsy, get a biopsy and test the patient. So again, because there is a discrepancy, especially for third generation, the discrepancy between tumor testing and plasma testing. So really, in the future, probably it's really going to be drug response to determine what is the most proper assay and testing platform. So in terms of using ctDNA to select treatment, the context really matters. If a patient is naive to target therapy, in the EGFR case, if the patient is having the EGFR sensitizing mutation, receiving the first-line therapy, in that case, ctDNA works great. What's in question is for third-line EGFR inhibitor, where patient failed the first line, will the ctDNA still work? So what we know for many years is that when people are refractory to target therapy, within each patient, there are actually multiple resistant mechanisms. What's shown here is EGFR after CRC patient after EGFR blockade. When we interrogate the MAPK pathway, what's shown here is multiple mutations occurred in the same patient. The same goes for amplification. MET and CDK are also amplified in the same patient. Most recently, this is in lung cancer after they failed EGFR inhibitor. In the past, we know about 50% of patients failed the first line would develop T70M mutation. However, if you really take a closer look at the T79 mutated patient, about half of them actually have multiple mutations in addition to T79M. And you would imagine those patients have multiple mutation probably won't be responding to T70M monotherapy that well. And indeed, this is the case. So a patient can have both MET amplification and T70M mutation versus patient only have T70M mutation. And you can see the ones have both MET amplification does not do as well as the patient have only T70M mutation. And the KM curve shows that. So this suggests in refractory setting, even though you see T70M mutation in a patient, that doesn't always mean the patient will respond because there are so many other factors in refractory, in acquired resistance setting. So this is a model, and I think the current thinking is we really need to profile the acquired resistant landscape of the patient and really try to use a combination therapy instead of just go for what's dominate after resistance. In terms of monitoring of response, ctDNA tends to be more sensitive compared to protein markers and compared to traditional imaging markers because it's a direct readout of tumor burden and the half-life is only 2 hours, so it's fairly real time. The example I want to show is for immunotherapy where we know for some patients there will be a delayed timeline and also there's pseudo-progressors. The patient actually have increased volume of tumor due to inflammatory response. So in this particular case, this is a melanoma patient treated with CTLA-4 inhibitor. As you see in terms of tumor volume by imaging, the tumor actually flared up at 3 weeks and go down at 6 weeks, and tumor size reduced at 9 weeks. If you look at ctDNA, at 3 weeks, you see a spike, actually suggesting probably massive cancer cell death, and then it become undetectable at 6 weeks, precede what you can see in image. So my last aspect of circulating tumor DNA is about minimum residual disease. What do we mean by that is for intermediate setting, stage 2 and 3, where a curative approach is actually the standard care, either by surgery or radiation. However, you don't really know whether the patient is really cured after surgery. What we found is if you take a measurement protein marker and ask 6 or 8 weeks later whether the patient is clean of tumor marker or not, the protein marker does a decent job. However, if you look at ctDNA, 6 weeks after surgery, if a patient is ctDNA clean, which means it's no residual disease, and you can actually spare those patients with all the follow-up chemotherapy. So this is a very active research area to how to apply ctDNA to spare people from further systematic treatment. So definitely early detection is a holy grail. The technology right now is not there yet, but for specific cases like genetic carrier, high-risk patient, smokers, there are ctDNA approach developed for those patients, for those individuals. So summary, ctDNA is powerful approach because by and large is tumor specific. It's a very clean biomarker. And we have next-gen sequencing and digital PCR to have reasonable sensitivity and throughput. Definitely in refractory setting, using ctDNA to guide treatment takes more work. And also we are engaged in minimal residual disease and early detection. With that, I ran over. Thank you. Wow, crystal clear.
No, I
Great.
have a couple of questions, actually. So
Yeah.
can you detect CNVs also with plasma, copy number variation with plasma?
That's a very good question. Yes, you can, but the traditional, the more common approach for copy number alteration, it only works when the ctDNA fraction is high in plasma. So PGDx have a fairly unique approach where you look at the novel genomic junction as a result of copy number gain. So imagine if you have a MET amplification, the MET gene get inserted into the genome multiple times. Every time it's back into the genome, there's a novel genomic junction. So if you detect those junction, that gives you better sensitivity. But by and large, it's challenging for next-gen based approach.
Thank you.
Thank you.
Any questions?